Good morning, everyone. We'll be getting started in just a moment. We're just getting our case presenter into the webinar. We'll be getting started in just a moment. Oh, okay, we're going to go ahead and get started. So good morning, everyone. Hopefully everyone's had a chance to take a look at the attendance code for CME. I'm going to go ahead and get us started here. So I'd like to welcome you to a CPC. We have an absolutely fantastic case for you today. Dr. Michael Levy will be joining us to discuss this case in the traditional unknown format, which means that the only thing that he knows about this patient is what he was given in a 2-page summary that he received about 6 weeks ago. And we do this so that he can walk us through his thought process about how he would approach this patient in real time without the benefit of already knowing the diagnosis. So we thank Dr. Levy in advance for his teaching today. Dr. Levy is going to be joined today by Dr. Schwalas, who will be telling us about this patient. Dr. Kozak from radiology will go through the relevant imaging. And later in the presentation, we'll hear from Dr. Yoon, Dr. Shi, and eventually Dr. Stagner, who will share the diagnostic test. We're actually incredibly privileged today that the patient herself is joining us, and we're going to hear from her at the end about her perspective on this process and what she's been through. So we're very much looking forward to learning from her as well. So with that, I'll get us started and invite Dr. Schwalas to tell us about this patient.
Thank you very much. So we will discuss the case of a 30-year-old pregnant woman who presents with right eye vision loss. Next slide, please. So the history of present illness is as follows. In the second trimester of her pregnancy, she was diagnosed with Lyme disease after developing a bullseye rash. She actually tested positive for Lyme antibodies consistent with acute infection, and she was treated with amoxicillin for 14 days. In the third trimester pregnancy at 32 weeks, she developed a right periorbital headache that was similar to her prior migraines without any particular pain with eye movements. She also developed decreased vision in the right eye, noticed that colors were dim, and complained of decreased light perception. Next slide, please. She was at that point evaluated at outside hospital at 33 weeks of pregnancy by an optometrist who noticed that the right eye had hand motion vision. An automated visual field was performed, but she did not have any responses in the right eye, whereas the visual field in the left eye was normal. The right eye was noted to have optic nerve edema. She was referred to a local ER where an MRI and MRV was done without contrast given pregnancy and was deemed to be consistent with right optic neuritis. She was treated with IV methylprednisolone, 1,000 milligrams per day for 5 days. Noted that her vision was subjectively brighter after this, but the acuity was objectively unchanged. Next slide. Over the next few weeks, her vision continued to worsen to the point where by 38 weeks of pregnancy, she had no light perception vision. And at 40 weeks of pregnancy, she presented to the Mass Eye and Ear. At that point, she reported no improvement in vision whatsoever, and she had ongoing right eye soreness. And next slide. Her past medical history was really only notable for the recent Lyme infection and migraines. She took prenatals and iron supplements. She lived with her husband in a neighboring New England state and worked in healthcare. She was no smoker, and there was no notable alcohol drug use. Family history notable for a brother with childhood epilepsy and a mother with macular degeneration. Next slide, please. So on examination, 8 weeks after symptom onset, the right eye had no light perception vision. It had an afferent pupillary defect on the same side. And she was, again, of course, unable to do visual fields in that eye, but the left eye was completely normal, 20/15 vision, normal colors. Both eyes had normal intraocular pressures. Can I have a next slide, please? So this is the fundoscopy from the first examination at the eye and ear. This is from the examiner's perspective, so the right eye is on the left. We're first looking at the left eye here. This is a nice crisp looking optic disc of normal color, normal vessels on it. In the right eye, there's blurring of the margins consistent with edema. The disc appears to be pale, and there's maybe a suggestion of abnormal vessels on the disc. Next slide. Optical coherence tomography was performed to better evaluate the optic disc edema. So you can see here that in the middle section where it says neuroretinal rim thickness, the right eye has a solid line, the left eye a dashed line, and the right line is higher. Next slide, please. And the measurements are just generally higher in the right eye, so that's consistent with edema. Next slide. This is an optical coherence tomography analysis of the ganglion cell complex in both eyes, but focusing on the right eye. Next slide, actually. You can see over here that there's already significant thinning, significant dropout in the thickness of the ganglion cell complex consistent with atrophy that is developing, whereas the left eye is entirely normal. Next slide. So the initial assessment was that this could be a severe atypical optic neuritis, and the patient was recommended to have a treatment for this, but she deferred further treatment until after delivery of her baby. Lab workup was start, and imaging was planned for after the delivery, in which she had 4 days later. Next slide. So this is a summary of laboratory testing. This is about 2 months after symptom onset. She had mild abnormalities of creatinine and alk-phosphatides, but otherwise the basic labs were normal, and she had negative antibodies for aquaporin 4 from a serum and CSF, and MOG antibodies from a serum, as well as negative Lyme testing at that point. She had mild elevation of the inflammatory markers, consistent with recent delivery. Spinal fluid was non-inflammatory with no cells. Next slide. At that point, an attempt was made to treat for presumed atypical optic neuritis with IV steroids followed by oral prednisone. She was also given plasmapheresis every other day for 5 sessions, and she was started for rituximab, 370 milligram per meter square weekly for 5 infusions. With this aggressive immunosuppressive treatment, she reported her vision improved slightly to about light perception level for a few days, but then returned to no light perception level. Next slide. So she was re-examined after receiving rituximab times 4 and plasmapheresis and steroids. She reported no vision. And so this is basically the exam was the same as we had just seen, with a normal vision and otherwise normal exam in a left eye, but no light perception and an afferent pupillary defect in a right eye. This is the progression of the fundoscopy over the intervening time period. What we can see here is that on the right side is the newer image. The optic disc maintains some swelling, but has become progressively more pale, consistent with progressive atrophy. And there is this previously noted cluster of abnormal vessels on the disc. Next slide. If we can invite Dr. Kozak to present the radiology, please.
Good morning. So this is the first MRI study we have in our hospital system, and these are coronal sequences through the orbit. STIR sequence on image left, post-gadolinium on image right. And the abnormality here really pertains to the right optic nerve sheath complex. It's prominently enlarged compared to the contralateral side, which is the normal appearance of the optic nerve. And you can see that it's diffusely STIR hyperintense and enhances modulously as well. Next slide. On this axial post-contrast sequence, this isn't really the best sequence to look at this, and we'll see a better sequence later, but you can see on the patient's right side, the optic nerve is enlarged, really just involving the interorbital segment of the right optic nerve. Next slide. And then on these diffusion-weighted sequences, there's a suggestion that there might be a little bit of restricted diffusion on the right again in that same location. Next slide. Elsewhere, there wasn't any other abnormality in the orbits. And the only other abnormality that was commented on in the report was this punctate focus of flare hyperintensity in the subcortical white matter of the left parietal lobe, which the arrow is pointing to. Otherwise, the brain parenchyma looked unremarkable. Next slide. Then we had a follow-up MRI done about 3 months later, and same sequences as the first slide I showed, with STIR on image left and post-contrast on image right. And there hadn't really been much change over that intervening 3 months. Again, it's enlarged. The abnormality is enlarged, STIR hyperintense, and diffusely enhancing right optic nerve sheath complex and normal left optic nerve. No other abnormality was evidenced in the right orbit. Next slide. Here are some better axial sequences through the abnormality. So on screen left is a T2 sequence, on screen right is a post-contrast sequence, and you can see this very fusiform globular appearance of enlarged intraorbital right optic nerve that didn't extend further posteriorly, and it's very homogeneous in appearance. Next slide. And I think that's it for imaging.
Okay, this is where I get to tell you kind of how I think through these kinds of cases, because I do see a lot of cases of optic neuritis. They tend to be the more severe ones that come my way. And it's not really that unusual that a patient could have progressive loss of vision, some pain with eye movements, often following some sort of immunological trigger like Lyme disease or vaccine or an infection of some kind. And so at first I thought, okay, you know, pretty typical optic neuritis. The MRI report even thought optic neuritis at first. But there were some odd issues in this case that I'll point out. And obviously it's a CPC, so we have to think broadly. Next slide, please. I like this idea here that, you know, doctors sometimes think a little too hard about cases. A stabbing pain, you say, the doctor says to the patient here with a knife sticking out of his chest. But again, in this case, there are some things that are unusual here. So I'd like to point those out. All right, so let's get started. Next slide, please. Here's my broader differential. Start with inflammatory infectious causes and some vascular issues. You saw the diffusion lesion. And we'll get into tumors. And then some issues that are pregnancy specific, as in this case. And then really rare things I won't dwell too long on now. Okay, next slide, please. All right, we'll start with inflammatory. That's kind of my bread and butter. We did get a story of optic neuritis on the MRI. We had a pretty good story history-wise of an immunological trigger and then progressive vision issues. And when you think about the causes of optic neuritis, the two big ones are either a monophasic optic neuritis or multiple sclerosis. And with multiple sclerosis, about 40% of patients will present with optic neuritis at some point. So it wouldn't be that unusual. And it doesn't mean that since her brain MRI was otherwise normal, except for that tiny T2 flare, it was pretty much otherwise normal. It doesn't mean it can't be MS. You'd still follow a patient like this, but more along the lines of something on the monophasic optic neuritis would be reasonable to consider. And that's what they did and started treating for. So that made sense at the time. Then when you look at those blue, dark blue pies there, you'll see that the rarer causes, the ones that I see a lot of, that cause severe optic neuritis. And these are the ones that get to no light perception pretty quickly. And that's neuromyelitis optica and MOG. And the big difference between them is neuromyelitis optica patients usually don't make much recovery, and MOG patients make a pretty good recovery most of the time. And they both cause damage and lots of swelling on the acute OCT and lots of thinning later on. So that's all consistent with the OCTs that we saw. And then when you think about some of the other rare causes, like mitochondrial disease that is non-inflammatory, but can cause some inflammation associated with it, and especially sarcoid-related optic neuritis, those are the cases that can get severe, cause permanent damage, and then can also persist for a long time. So that was kind of at the top of mind when I heard about this case that really wasn't responsive immediately to steroids, or maybe a little bit, but then persisted for so long. Okay, so next slide, please. So monophasic optic neuritis often follows some immunological stimulus. We heard about Lyme disease in the second trimester. That's pretty good. they don't tend to be super severe in terms of getting to no light perception. They usually hit 20/60 or 70 or so, and then they tend to get better over a few weeks. That's the typical course of monophasic optic neuritis. It's not usually this severe. So when it's this severe, you have to think more broadly. And then some cases of monophasic optic neuritis are not even treated, and they still do better. And by the time they get treatment, sometimes they're offered treatment, sometimes they're not. They often just get better on their own. And in this case, though, although it was a single event with no other disease, no spinal cord disease, no brain disease, it's a single one-sided optic neuritis, it's still consistent with monophasic. So at least we keep that on the differential. But the other things that are unusual about this is how severe it is, how prolonged it's gone, and then that MRI. I don't know if we'll be able to bring it back up at some point, but that MRI looked weird for optic neuritis. It had this massy lesion. It was really swollen. I mean, on that coronal section, you saw the good optic nerve, that's its normal size. And this one looked 5 times thicker. You don't usually see that with optic neuritis. It doesn't usually look kind of bulky. It usually looks kind of just swollen, fusiform wise, not like, shaped like a mass. So that kind of put me off from optic neuritis. Next slide, please. Multiple sclerosis is very common, so it has to stay on the list. The lesions tend to be small, focal, not super swollen like this. They often just get better on their own with good recovery. On brain MRI, you often will see some disease that has already started. And even if you don't, then you'd still follow to make sure that none will progress. You can look for oligoclonal bands in the CSF. And consistent with multiple sclerosis in this patient is the person's age, and she's female. But what's unusual is that this lesion is huge. Anything like this, this big, brain, spinal cord, or optic nerve, any lesion that's huge often puts me off for MS. The symptoms were severe. The recovery was so poor. There were no other brain MRI lesions. There were no bands in this patient's CSF. I'm not sure if that was discussed, but that was conveyed to me. And also during pregnancy, MS tends to go into remission. Obviously, this happened during pregnancy, so that's a little unusual too. Next slide, please. Okay, then the NMO-MOG. This is what I see most of in my clinic because it causes severe vision loss. You tend to see horrible lesions on MRI. They usually extend across the entire optic nerve. The optic nerve is about 50 millimeters from the retina to the chiasm, and involving more than half of it occurs in NMO and MOG a lot, and it's enhancing and ugly and swollen. And these diseases do often spare the brain, just like this case did. With aquaporin 4 antibody, the recovery is poor, and with MOG, the recovery is pretty good. Now, the patient first presents and these antibodies are pending at the Mayo and you don't know when it's coming back, you can't really give this kind of prognosis to patients. But if it does come back and the patient's still in the hospital getting plasma exchange, you can often tell them, oh, good news, you have MOG antibodies. This is going to likely improve over time, over 3 to 6 months. Or if you have aquaporin 4, you really want to be as aggressive as possible in treating because outcomes are not as good. So everything is consistent in this case with aquaporin 4 and MOG disease. But what's a little bit unusual is that these are rare conditions, although I see a lot of them. They're 1 in 100,000 or 1 in 50,000, so pretty rare. And then also that MRI lesion, that massy type thing, which I'll talk about in the tumor section, that's what first thing that came to my mind was, that is a weird looking optic nerve lesion. Next slide, please. Okay, so the sarcoid issue also kind of made me think that subacute onset, these are patients who have a lot of brainstem meningeal inflammation. You sometimes see it with systemic sarcoidosis, but sometimes it's just neuro, and sometimes it's just optic nerve. And then the cases that I hear about that have this persistent enhancement on MRI that takes forever to go away, and that you give them steroids and then just slowly, like we heard about in this case, got a little better with a lot of steroids. Sarcoid patients will need 6 to 12 months of steroids, and then they slowly respond. And it's terribly slow. And but that's kind of what I when I heard about this persistent disease, coming back in over and over again, and MRIs are unchanged and still enhancing, I thought, "Ooh, this could be sarcoid." But then I saw that MRI and I was like, that is still too big and bulky for even for sarcoid. Plus, with sarcoid, you tend to see more perineuritis and nodular lesions along the meninges around the optic nerve and less invasion into the optic nerve. So slight, you might say that's just a slight difference. But again, when I saw that optic nerve on MRI, I thought that looks too big and bulky. Okay, and next slide, please. I think we're gonna now move on to the section of vascular disease. Oh, infectious. So there's a billion bugs. And if you remember your infectious disease class, the lists with genus and species, just these incredible number of different bugs, but just the common ones to think about for optic nerve disease are HSV and VZV, and Bartonella, especially if there's this macular star that the ophthalmologists love to talk about. Syphilis, which I've seen once in my life, but which there are textbooks written about. And then, as I said, a billion more bugs. And a lot of these, there are good tests for these now with PCR and very treatable, so you don't want to miss them. Next slide, please. Okay, so vascular diseases are basically broken down into either arteritic or non-arteritic. The arteritic ones, the classic ones of giant cell arteritis, the painless vision loss, or polyarteritis nodosa in 50-year-old men. And for this, we really do depend on the ophthalmologic exam and the fundoscopy, and they'll say, oh, we see this vascular anomaly or that, or temporal artery biopsies, tenderness to palpation, elevated ESRU, remember all that stuff from giant cell, and we didn't get any of that story. Now, on the non-arteritic side, you typically expect some vascular risk factors, hypertension, hyperlipidemia, that type of thing. Pregnancy is a hypercoagulable state, so I kind of thought, well, could this be some sort of like venous congestion or something like that? But these non-arteritic vascular optic neuropathies, they just slowly get worse, and it's really, really difficult to do anything about it. But they do tend to be a lot slower. You try to modify their vascular risk factors, but these are people in their 50s, 60s, and 70s, and it's just kind of a progressive thing. And then sometimes it can involve the other eye. But on MRI, it's not supposed to be these big honking, these swollen enhancing lesions. They do tend to be more subtle, and MRI often is negative or normal looking. Okay, next slide, please. So then comes in the tumor, and that's kind of what I jumped to when I saw this MRI was, wow, that's a big swollen optic nerve. I wonder if this could be a tumor. And of the tumors in the optic nerve, half of them are optic nerve gliomas, but they tend to be in kids. These are like those benign pilocytic astrocytoma things that the kids get in the brain sometimes too, and they tend to be spontaneous, but sometimes associated with neurofibromatosis. And the treatment is difficult because resecting it is going to remove a lot of, or most of, the optic nerve, and that's going to cause permanent vision loss. But there's not much more to do, because if you try to radiate or something like that, tends to cause even more damage. Meningiomas, kind of like sarcoid, tend to start the growth on the outside in the perineuritis space, and then they don't really invade into the optic nerve. They just kind of grow around it, squish it. And since this is not a child, I thought, oh, maybe this is a meningioma, since meningiomas are pretty rare in kids and much more common in adults. But the MRI didn't look that way. It looked more glioma-ish, so hard to say there. And then I thought, wow, one of the weird things that can grow into an optic nerve is this thing called the melanocytoma, which is like a nevus, like a birthmark on the retina that then grows back. And so one of the things I asked Dr. Schwalis was, is there a nevus on the retina, this dark pigmented area that could be growing back into the optic nerve and causing a tumor there? And he told me that all that dark stuff around the optic disc, that's just what fundoscopy looks like. So based on that, I don't think it's as much as is likely. Plus, they're pretty rare. Next slide, please. Here's just pictures of what a glioma looks like. In box A there, you can see how much of the space of the optic nerve the tumor can take. But they do tend to be, sort of this, they call it pilocytic because it looks hairy in panel B. You can imagine those kind of hairy looking astrocytes with big nuclei. And then in panel C, there's Rosenthal fibers there. So that's, I think if we see pathology, I think, keep this in mind because this is still my top choice right now. But as we go through, I'll kind of explain why I think that. Next slide, please. Yeah, so we went through all that. Okay, next slide. And then a couple of just pregnancy specific things. I thought about, pregnancy is a hypercoagulable state. There's lots of potential fluctuations in blood pressure and changes in blood volume. And with preeclampsia, could this be some sort of pre-eclampsia optic neuropathy? It would be on the ischemic spectrum. So I thought about that. Maybe related to an antiphospholipid antibody syndrome. I think she'd been tested for some, but then there were a few antibodies that were not on her list. And I thought, could this possibly be some sort of vascular issue related to pregnancy? So I think that has to stay on the list. And then intracranial hypertension associated with pregnancy can cause pressure on the back of the retina. You get swelling like we saw in the OCT, but it tends to be bilateral because how could you just cause swelling in one eye? So I kind of put that one at the bottom there. And then the last slide, just rare conditions to keep in mind. I think I've seen 1 or 2 cases in my life of this PRIMP5 paraneoplastic disease associated with feminine cancers. And there are a whole bunch of mitochondrial diseases like Leber's that for which we have pretty good genetic testing for, although it doesn't, obviously this is really would be unusual for a mitochondrial disease given the swelling on the MRI and that mass-like looking lesion. Could also be, before I saw the MRI, I heard about toxic conditions. Could she have taken, maybe it wasn't, I think she got amoxicillin for her Lyme, but Cipro can cause some toxic optic neuropathy, nutritional deficiencies. Obviously, these aren't likely. I just have them on the list of rare things to keep in mind. But with that sort of optic nerve lesion and how it persisted over time and how poorly responsive it is to steroids. Steroids would be my first choice for something like this, but given how intractable it was and how unusual all these other things could be, it occurred to me that a biopsy would be pretty much the only way to figure this out. Otherwise, if it's a glioma or something like that, it's just going to get worse and worse and not solve itself. So on the next slide, I think, what I would recommend is that we're at the point now where we have to get a biopsy. I don't usually recommend biopsies of the optic nerve, but we've really given steroids a good hard chance to treat any sort of inflammatory process, given the persistence and the different treatment options. If it were a glioma, I think that a biopsy of the optic nerve is the only option here.
All right, thank you, Dr. Levy, for this excellent discussion. Next slide. So as the neuro-ophthalmologist who was confronted with this case, let me just very briefly summarize how I thought about it. So, we were dealing here with a young pregnant woman with subacute, painful monocular vision loss that progressed from color desaturation to this severe vision loss, and there was an afferent pupillary defect, and there was an abnormal optic disc, and there were also some abnormal vessels on the disc. And then she was re-examined after steroids and aggressive immune suppression. Her vision was unchanged. And then, as Dr. Levy picked up on, there was this massive and persistent enhancement of the retrobulbar optic nerve. Next slide. So as a neuro-ophthalmologist, just to backtrack, how do I localize an optic neuropathy? I try to teach my trainees the 5-finger rule. These are the things that you need to check: visual acuity, color vision, visual fields, pupils, and then the optic disc appearance. Next slide. The visual acuity tends to be dramatically affected in the optic nerve for the simple reason that it's the only cable that connects the eye with the brain. So, if you disconnect the cable, there will be very little vision coming through. So in a severe optic neuropathy, visual acuity will be disproportionately affected. Next slide. Color vision tends to be a very sensitive measure of optic nerve function because most of the optic nerve are projection tracts from the central, from the macula, from the center of the retina that has color vision. So you can use Ishihara color plates, or simply showing, in red objects to the right and left eye is a good way to pick up that you could be dealing with an optic neuropathy. And indeed, our patient did initially have color desaturation as an early complaint. Next slide. Visual field testing helps you localize lesions along the entire optic pathway. In this case, the patient was not able to do a visual field because of a poor vision in the affected eye, but it is still critically important to check the other eye with visual fields, make sure that there's nothing there, because if there was, you could have been dealing with an optic chiasm lesion. But in this case, this was a monocular problem. Next slide. And then the relative or there's no vision, absolute afferent pupillary defect. So this is the swinging flashlight test, where when you swing the flashlight from the good eye to the bad eye, both pupils dilate. Both of them do, because the pupillary neurons in the brainstem get input from both sides. And then the efferent aspect is monocular. So you can see here in this picture on the right, as the flashlight is shown from the patient's right eye, which is healthy, in this case to the left eye, which is the sick eye, both pupils dilate. Next slide. We did have that as well. So we have diagnosed an optic neuropathy, but then we, as Dr. Levy told us, there's this huge list of things, traumatic, ischemic, increased intracranial pressure, compressive lesions, inflammatory lesions, neoplastic lesions. How do we sort through that? Next slide. Well, clinically, we can eliminate a whole bunch of these just by virtue of it, with a time course and that there's pain involved. A number of these, such as ischemia, glaucoma, metabolic, nutritional, genetic problems, are going to fall to the wayside. Next slide. And then the MRI definitely helps because, in this case, we are dealing with an intrinsic enhancement of the optic nerve. And so, we're not going to see that in increased intracranial pressure. Some other sort of external compressions like thyroid eye disease, pituitary disease or something like that, we're not going to be dealing with because we've seen the MRI. Next slide. We had normal labs with normal CSF, including no oligoclonal bands. And so that makes some of these, infectious inflammatory causes less likely, although it isn't absolute, because lab testing is not perfect for some of these conditions. Next slide. And then, yes, yeah, there we are, yeah. And then, as Dr. Levy asked for the MRI to come back, we were dealing with this sausage-like sort of, very bulky enhancement. It was just too big, and it persisted for too long for me to be comfortable with this being optic neuritis. Next slide. And so that sort of, eliminated a lot of these inflammatory causes that we're still dealing with. And so I arrived at the same conclusion: we must be dealing with a tumor. Next slide. And so glioma and optic nerve shift meningioma are the two most likely ones. And then I wanted to come back to this optic disc appearance, where we saw these abnormal vessels in the sick optic disc. And these are optociliary shunt vessels. And you can see them here with a green arrow pointing to them. You don't see them in a left eye. So what are these? Next slide. So you can think of these as the caput medusa of the optic nerve. So normally the drainage from the eye would be for the central retinal vein through the optic nerve. But if there's something squeezing the central retinal vein, then the venous blood will have to find a different path. And so it will create it will expand these channels, and the blood will flow through a choroid. So these are optociliary shunt vessels, as we're seeing on this disc. Next slide. So when we see that, what are we dealing with? Well, we could be dealing with an after effect of a retinal vein occlusion. We know that's not the case. And by far and away, the most common cause is going to be an optic nerve sheath meningioma. Less commonly, you could see this in other conditions such as glioma or drusen. but it becomes very suspicious for an optic nerve sheath meningioma. Next slide. So I arrived at a similar clinical diagnosis of optic nerve tumor. Clinically, it looked more like an optic nerve sheath meningioma. Radiologically, it looked more like a glioma, and we needed a biopsy to figure it out.
All right, thank you. I'm happy to give an orbital surgeon's perspective on this. I will say I was really interested when I got this consultation from Dr. Schwalitz for a question of an optic nerve or an optic nerve sheath biopsy. Next slide, please. This is something that I get queried for about once every 10 years. And here, just in the CT scan, which is showing similar to the MRI findings, the thickened and asymmetric optic nerve and its sheath. And so in doing a biopsy of this, it's rarely done because oftentimes biopsy itself can result in vision loss. And in the case of this particular patient, with the vision having been lost for so long, that risk was very low. And we obviously want to come to a diagnosis to find out if there's any non-eye related treatment that might be necessary. Next slide. So we took her to the operating room, and this is just what the surgical setup looks like. If people haven't seen that, that's me in the middle with my two fellows. We're at the neurosurgical microscope. And on the right, you can see the screen, which is displaying what we're looking at through that microscope. Next slide. And so there's a few different ways to get to the optic nerve. And this is the eyelid approach. This is the surgeon's view. So this is looking at the right eye. You can see there's an incision already made there medially along the eyelid. And this video actually isn't of the patient, but it is of an optic nerve sheath fenestration, which is the exact same approach. But we'll actually have a good opportunity to see an otherwise normal looking optic nerve as seen in this video compared to the patient. So just using retractors can bluntly dissect back there. And we're in fact looking at the optic nerve there. It's a white structure going from bottom left to top right. It's probably about a third of the width of that malleable retractor on the left. So it's pretty small. There's a couple normal looking vessels on the top. Could you click, please? And this is a photo of the patient. The video itself wasn't so great. You can see it's a little dark, but this is a still. And what I'm able to see in this is that the color is darker. That's even accounting for the differences in the optics here. It's much thicker, it's darker in color, and there are a lot more vessels overlying it. Next slide. If you could, thank you. The next stage here, I'm using a sickle blade, and this is under the magnification of the microscope, and just making incisions into that optic nerve sheath, and you'll see a gush of fluid. You see that filling the field there, and that's what we would see in idiopathic intracranial hypertension, where that CSF is coming out. Next slide, please. And this is what it looked like after I made those initial incisions into this optic nerve. You can see that there's a thickened, irregular, sort of bumpy appearance to it, and there's a little bit of bleeding there from the hypervascularity. Next slide, please. Next, I use forceps and these fine scissors to create a window, in this case for the fenestration, and can pull the sheath away from the underlying optic nerve. And here it is after that window has been made. Inside of that sort of irregular rectangle there is the optic nerve. It's totally normal, it's white, and there's a nice space in between there. Next slide. And here, I'm not even able to see that optic nerve directly. The sheath is so thick, I'm grasping it with the forceps on the right and the scissors on the left, and was able to get a representative sample, however, not able to see the optic nerve as you would see in this fenestration video. Next slide. And finally, the closure is just a skin closure, zooming out here in about a 1 centimeter incision. Okay, I think that's all I have. Thanks.
Okay, so let's take a look at the biopsy. Next slide. So at scanning microscopy, we see here fragments of an eosinophilic cellular tumor that's admixed with orbital fat and small fragments of bone, potentially, or calcification, as indicated by the arrow. There's no glial tissue here, so there's no brain or optic nerve tissue. Next slide. And this eosinophilic mass on higher power shows a distinctly lobulated or nested architecture. And there are no conspicuous psammoma bodies or these lamellated concentric calcifications. Next slide. These neoplastic cells are growing in this sort of syncytium. They have really indistinct cell borders and abundant eosinophilic cytoplasm and relatively uniform round to oval nuclei with tiny nucleoli in some of them. There are intranuclear pseudoinclusions easily identifiable, which is characteristic of this tumor. Next slide. There are no features of malignancy or atypical features for this tumor. So no increased mitotic activity, no sheet-like growth or increased cellularity, no necrosis, no prominent nucleoli. And as we mentioned, there's no glial tissue in the specimen that's for invasion, which would be concerning. Next slide. The cells show diffuse nuclear staining for progesterone receptor, which is common in this tumor. Next slide. And the Ki67 proliferation index, or MIB1 immunostain, is quite low. It's less than 1%, which is useful to predict recurrence in this tumor. Next slide. So the final diagnosis is a meningioma, meningothelial type, WHO grade 1, which is typical for this location. Optic nerve sheath meningiomas are typically low grade.
Okay, by then I had the advantage of the pathology to know that this is a meningioma. Go ahead and so as an optic nerve sheath meningioma, our standard is to offer definitive radiation therapy with the primary goal of arresting tumor growth. And by doing this, this can prevent further proptosis that would otherwise occur and lead to future need for enucleation, which is the historic standard of care for management of these tumor prior to realization of the role, the efficacy of radiation therapy. In patients where the diagnosis made earlier on and symptoms are limited, oftentimes they're able to preserve and reverse the vision loss. But even though we thought that was unlikely, that was still a secondary hope of preserving the limited vision that she had, minimal light perception, I think. And then also to help reduce pain and pressure that can increase over time with these tumors. And this is a long-term goal because the short term in the first year after radiation therapy, we typically cause inflammation, which can often worsen the pain, pressure, local symptoms that hopefully abate in years thereafter. Next slide. Her treatment was proton radiation therapy. We offered a 6-week course of daily treatment, Monday through Friday, weekdays. The rationale for proton radiation over standard photon-based radiation therapy is that proton allows us to minimize collateral radiation exposure to surrounding tissues. And by doing that, we were able to remain off the entire left eye and most of the left orbital contents, only minimal, I think, radiation spillage there. And this, of course, then allows us to avoid any potential radiation-associated side effects to the contralateral eye and orbit, which is all the more important given the limited lack of vision in the right side. The use of proton therapy also allows us to localize the radiation in the right orbit to stay off the brain and, importantly, the pituitary gland, which is very sensitive to radiation, and it allows us to avoid radiation-associated hypopituitarism. Next slide. In terms of her tolerance of the 6-week course of radiation, she did develop pain behind the right eye that was progressive throughout the day and managed with acetaminophen. There was more pronounced ptosis, eyelid drooping by the end of treatment. She felt that her eye lagged behind her left eye when trying to move it. There was no improvement in her right eye vision, unfortunately, and she developed the typical expectant progressive mild fatigue over the course of treatment. The response to radiation therapy, this is just looking at it 1 year. The prior to radiation, we've already seen these images on the left, the enhancing lesion that's surrounds the entire lens of the optic nerve. And then a year later that it is at least no worse. And in subsequent years, we hope to see continued partial shrinkage, but this will always remain there on our future scans. So since completion of radiation therapy, she continues to have persistence of symptoms. I think we'll hear the latest version shortly, but at least in the first year, continue to have headaches that were moderately severe, actually, managed with a combination of either acetaminophen or ibuprofen, and became a little bit less frequent in severity and frequency over time. Her vision remained essentially not blind on the right eye. Ptosis worsened when she was tired. And her baseline normal left eye vision, although normal, she noted that her left eye became sore with strain and long days of greater dependency, or actually complete dependency of vision on that eye. And even though she had low energy, she had phenomenal stamina and continued to work full time as a nurse practitioner. Thank you.
Thank you, Dr. Shi. I want to say thank you to all of our discussants, and particularly to Dr. Levy for taking on this really challenging case. One I think everyone would agree the right diagnosis was not gettable, and what you came to is that a biopsy needed to be had because this didn't look like what it ended up being on path. And so we really appreciate you walking us through your thought process about the case. And now we have the pleasure of hearing from the patient who agreed to share a little bit of her perspective of what this was like. And so we're incredibly grateful to have you join us this morning.
Hi, thank you. I really appreciate the opportunity to speak here about my experience, and in preparing what I wanted to say, it really had me kind of reliving this experience all over again. I think for anyone who goes through any kind of treatment for anything, you're kind of in like a what's next step. And when it's over, it's a big blur. I think my treatment was like over 6 months. And so in thinking about everything that I went through, there was a couple things that I really wanted to speak about. So firstly, it was really difficult when I first noticed my vision change to even explain it. I remember I was like driving to a wedding and I rubbed my left eye, and in just that brief period of my left eye being closed, all the lights turned off, like the headlights on cars. It just seemed like it went from like midday to like nighttime. And I thought, well, that's like kind of weird. But you know, like I'm in healthcare and I'm like, okay, well, maybe it's just like a headache or something because I had a headache all morning. I'm like, I'll just go to this wedding and then go to an eye doctor in the morning. And so, you know, when I presented to an optometrist in the morning, I could see all the vision charts and I could, you know, get all of the like acuity tests, but I just kept saying, I just can't see the light. Like the light is not there. I can't see your light. And he was like, I have no idea what's going on. So he sent me to the emergency room. And that was really my first presentation into like the healthcare system for this. You know, in reflecting, I think the one thing I still had a lot of regret over was just the delay in the correct treatment and then the diagnosis of my tumor. You know, when I first presented to the ER in New Hampshire, they treated me with steroids for optic neuritis, but I was told it's definitely not a tumor. And so I had this like reassurance of like, okay, well, you know, it's going to get better with some steroids and that's such a relief. You know, unfortunately, when I discharged, they wanted to see me in a week and then they weren't able to get me in for, you know, a few weeks. And then unfortunately, the neurologist on discharge was sick the day of my follow-up. And so my follow-up appointment got pushed a month. And so by this point, I, you know, had been out of the hospital for almost 2 months. And when I went to see my ophthalmologist up here, he was like, you have not seen the neurologist yet since discharging. He's like, I'm sending you to Mass General. And so that's when I presented with Dr. Trollish. And thank goodness I did, because I think, you know, even though by that point it was such a delayed treatment, I think things moved forward a lot quicker at that point. You know, it's tough for me to wonder, had I, you know, been followed up sooner, or, you know, had I been treated more aggressively for optic neuritis initially, or someone familiar with tumors seen me, you know, could I have had some vision, you know, left after treatment, you know, and I guess it's always easier to think of that after, you know, and I guess we'll never know. But it did, this experience did make me realize how easy it is to get lost in the healthcare system. Even for me, someone in healthcare who's familiar with how things work, did get lost briefly in that period. You know, I also wanted to speak a little bit about my experience at Mass General, being pregnant at the time, and then completely blind in my right eye. was really scary. And then once I gave birth, we were admitted. My daughter was just 5 days old at that time. It's definitely not the postpartum experience that I imagined having. So I just wanted to take a second to thank Dr. Tralish for like everything he did to make me comfortable. When he called, he told me there was a bed on the unit, and I literally cried for like the entire time packing because we had this 5-year-old daughter. We had to drive an hour and a half to this hospital for a 2-week stay. I didn't even know really how to change a diaper. And then we're like leaving everything that we had, prepared to take care of her to go to this like hospital room for 2 weeks. And also kudos to like the neurology floor nurses, because if I was a neurology nurse, that would not be my thing, having this like baby on the unit for 2 weeks. And everyone just made me feel so comfortable. There's everything that I needed there, all the consultants. And then every time the team rounded, they included Madeline in the care of like the day. Okay, like what are we going to do today? And, your dad's here, and, how's breastfeeding going? And here's the meds you're on, and here's how they affect breastfeeding. And so I think I just want to say, like, everyone's going to take care of somebody postpartum at some point, and just giving that full experience as much as you can during treatment is just so important. It really helped to relieve a lot of the stress and guilt I had, that essentially my entire maternity leave was focused on my treatment and not really like me and her. So it's been a couple years now, 2 years, and I did not get any vision back, but I do feel like I've adapted fairly well. Initially, my main thing was my depth perception. I mean, I would like be pouring something and just be completely away from the cup. But I haven't noticed any issues with that. Also, my husband says that he can't notice, but I feel like I do have a little bit of a lazy eye, which I'm very self-conscious about. But I guess in the scheme of things, I'm fairly lucky that this wasn't, cancer or something a lot more serious. And so I think what to take away from, this whole presentation is I just really hope that, people are more familiar with the presentation of optic nerve tumors, and that, it stays on a differential for the patients that present similar to me. And that hopefully, it encourages providers to refer patients to facilities a lot sooner and not let them kind of slip through the cracks, so that potentially they could have some vision remaining after treatment, because that would have really meant the world to me, as being able to still see something out of that eye. Thank you so much.
Anya, thank you so much for joining and sharing your perspective. Makes it a really special CPC. We do have time for questions. We have about 5 minutes. If there are anyone who has questions, I'm looking in the chat. Mostly congratulations for a wonderful discussion. If there are any questions, I can see them in the chat. If anyone has any questions for any of our discussants.
Can I just emphasize one quick point that I think that it needs to be mentioned here, is that meningiomas can sometimes grow very, very quickly during pregnancy because of a presence of progesterone receptors. So one piece of the puzzle here may be, why did the optic nerve get affected so quickly, so dramatically? It may be because of these progesterone receptors in a meningioma.
Those were seen on pathology. Is that correct, Dr. Stagner? That was one of the things you pointed out on pathology.
Most meningiomas, especially low-grade ones, have diffuse progesterone receptor expression, like probably 70% or so. So yeah, this one also did, which we had actually stained for after the fact. It wasn't really a diagnostic thing, but to see if that would explain some of the rapid growth in pregnancy.
There's a question in the chat, given the response to progesterone, whether or not there's been any discussion about risk of future pregnancies, whether something like this could happen again. I don't know if anyone has any thoughts on that. Oh, Helen, I can't hear you. You're not muted, but for some reason I can't hear you.
Okay, sorry. Is that better?
There you go. Yep.
It's actually a common question I get since I treat a lot of meningiomas. We don't actually deter patients from subsequent pregnancies. I think there probably is always a little risk, but thus far it's once treated, either resected or irradiated. It's most patients don't have progression of the treated tumors.
We know from other tumors that after proton beam therapy, like uveal melanoma, for example, they go into this like senescent state. So I would imagine even if you had a progesterone surge for the future pregnancy after proton beam, it'd be low risk of coming back.
They were the person who's asking the question meant in the other eye, not particularly that tumor coming back. Do we know
I think
anything
it's
about that?
the similar thing to like breast cancers that grow during pregnancy. It had to already be there. It didn't cause it. So the chance of her having another already, present meningioma on the other side without NF2 or something would be.
Agree. It's usually the meningioma is already there. It's just the pregnancy with elevated hormones promote growth, and then that's what makes it symptomatic. It won't actually put her at risk of developing an independent de novo meningioma otherwise.
Thank you. And then one last question, Dr. Kozak, if you're still on. The question was, were there radiological distinctions between glioma and meningioma in this situation?
Yeah, I think it's a little bit tough in this case. As was mentioned, the imaging appearance was more suggestive of a glioma than a meningioma. And looking at the literature, there are at least one or two case reports of meningiomas looking like this. But the appearance is more typical of a glioma. Meningioma tends to have that more tram track appearance classically.
Thus the biopsy necessary for diagnosis. Okay, well, I would like to end with the last thing that came into the chat, which was many thanks to the patient for her fortitude and her message about seeking care soon, despite the pandemic during this ordeal, and best wishes to Madeline and her parents. So thank you all very much for joining us today, and look for this in the New England Journal in the coming months. Thanks very much. Enjoy your day, everyone.